These were the fields, but possible only in 17 because these were atrophic cases, and we had minimum 6 weeks follow-up to 24 months. We tried to establish and look at outcomes in terms of visual acuity, visual fields, and the disc edema resolution. And we had, finally, these were our results. We had 6 unilateral and 21 bilateral cases. Of the 6 unilateral with good vision, we operated on those with the poorer vision. Of the case with poorer vision, we had 1 child which had low vision in the left eye, so we operated in that eye. But we had 1 patient with no PL, so we operated 1 eye of that patient. Among the 21 bilateral, we had good vision. 6 eyes of 3 patients from 6/6 to 6/18. 6 eyes of 6 patients with 6/18 to 6/60. In case of the poor vision, we had 16 eyes of 11 patients with counting finger to 5 meters, but we had about 14 eyes with either hand movements, PL, and no PL. So what we found is if you operate in time with good vision, we were able to improve vision or maintain them, and visual fields also improved or stabilized. In those in which we operated in time just before of low vision alone, they did well, either improved or stabilized, but those in which there was no PL or just PL or hand movements did not improve at all. So what we tried to summarize is out of the 48 eyes, visions which were better than 6/60 all did well. Those with 6/60 less had ambulatory vision, but those with poor vision had no change, which means of the 34 eyes, or the 71% with at least counting finger to begin with, maintained ambulatory vision. That means were successful in all cases, of which vision improved in 23% and stabilized in 48%. So basically, we showed that there was complete resolution on B scan by about 4 weeks. It starts within a week. Visual fields improved in all, and there was no vision-related complications. What we know is that ONSF does very well in cases, in early cases where you are able to pick up and the fields and vision is not affected. But we were able to show that even in cases of atrophic papilledema, it still works, and it can salvage vision in those with flat, pale discs. Ambulatory vision is possible if the vision is start to begin with is counting fingers, but no role if there is PL, and B-scan is a very good tool that we can use to detect these cases. Now, another role of B-scan, what I want to put through to you, especially prior to an optic nerve sheath fenestration. Now, this was a patient that reported to me on 30th October, which was a Saturday. You can see the vision is, there is significant pallor and disc edema. Central vision was fine, but if you look at it, there's significant elevation on OCT, the RNFL thickening, fields were completely affected, yes, including the macular field, which tells me, yes, I have to go in for optic nerve sheath fenestration, so I scheduled the patient on Monday. And Monday, as my routine protocol of doing a pre-operative B-scan, when I do, I see no fluid. I was like, I saw this on Saturday, there was fluid, what happened to it? The left eye, right eye did not have so much constriction, so I waited. But over 3 months, you can see both the eyes are doing well, and the fields have restored back to normal. Hence, I want to summarize that when you are looking at things like this, you can always use your B-scan to differentiate a papilledema, pseudopapilledema, or other cause of disc edema. Like, for example, the same patient, when we see, if you do your B-scan, you'll be able to pick up a drusen. This patient had optic disc drusen, which you can confirm by CT scan or an autofluorescence to tell you that, yes, this is drusen only. And in the second patient, where you know this is a frank papilledema because of the history, the presentation, you know this is, but you can definitely confirm by doing the B-scan, looking for the hypoechoic crescent, seeing the size, which is definitely enlarged, and confirm your diagnosis. And finally, a patient like this, who had a sequential vision loss, you see disc edema here. Yes, you would again do your normal B-scan, but here you will not find any fluid because we are looking at both eyes atypical optic neuritis. So where in doubt, you can really go back and use this scan to help you detect a lot of things. And the other thing is, in case of increased ICP, you can in fact pick it up even before the axoplasmic status comes into play and the development of papilledema. And more importantly, in atrophic discs, to detect recurrence of ICP, because these states will not elevate again, but you can definitely see if it's coming back, monitor them, and help it to prevent the resolution of recurrent cases. So thank you very much for a patient listening.
Yes, thank you, Dr. Jyoti. Maybe we will have a discussion after all this.